Advanced lung-sparing procedures like sleeve resections have reduced the frequency of the operation, but a complete pneumonectomy remains a high-stakes, last-resort procedure. Guidelines target sub-7% mortality, yet morbidity spans 15 to 75%, spiking significantly for right-sided procedures. Survival requires a three-legged preoperative assessment: FEV1 for mechanical airflow, DLCO for gas exchange, and VO2 max for cardiopulmonary reserve. Yet even with perfect screening, removing an entire lung creates a massive biological vacuum inside the chest cavity, leaving the patient highly vulnerable to sudden failure. Surviving the operation itself only initiates a physiological clock. The greatest immediate threats emerge not from the scalpel, but from the body's violent attempts to equilibrate the empty hemithorax. The most dreaded clinical scenario occurs within the first 72 hours, a patient experiencing sudden postoperative desaturation and rapidly progressing into hemodynamic shock. In this window, the clinical presentation heavily overlaps. Symptoms like hypoxia, hypotension, and tachycardia actively mask distinctly different, diametrically opposed mechanisms of organ failure. This diagnostic decision tree illustrates the algorithmic approach required to rapidly differentiate acute deterioration. It branches into three distinct lethal pathways that must be ruled out: cardiac herniation, post-pneumonectomy pulmonary edema, and early bronchopleural fistula. Applying the wrong intervention to these overlapping symptoms, like administering fluids for shock when the lungs are already drowning, ensures a fatal outcome. Precise algorithmic-driven differentiation is the specialist's only lifeline. The first branch is cardiac herniation, a severe structural disaster carrying a 50% mortality rate. It occurs almost exclusively after an intrapericardial pneumonectomy, where the pericardial sac surrounding the heart is opened and left unpatched. The triggers are strictly mechanical. A sudden change in patient positioning or excessive suction applied to the chest drainage tubes can draw the heart out of its protective sac. This top-down schematic demonstrates the specific right-sided mechanism of failure. The heart twists clockwise, slipping entirely through the right-sided pericardial gap. This extreme torsion mechanically pinches the superior and inferior vena cava, causing catastrophic inflow occlusion. Blood cannot return to the right atrium. By contrast, a left-sided herniation involves the left ventricle itself falling through the defect and strangulating, which directly impairs ventricular filling, contraction, and coronary perfusion. This high-contrast chest X-ray recreation displays the critical diagnostic indicator, the pathognomic heart-in-the-back sign, where the massive cardiac silhouette shifts entirely into the posterior right cavity. Patients will also present with cyanosis and severely elevated central venous pressure. Immediate mechanical salvage requires placing the patient in a lateral decubitus orientation, meaning they lie on their side with the remaining good lung down, followed by an emergency return to the operating room. Because herniation is a purely mechanical obstruction, pharmacological resuscitation is useless. Survival depends entirely on spatial repositioning and an emergency mesh patch repair of the pericardial defect. The second algorithmic branch is post-pneumectomy pulmonary edema, or PPPE. This complication affects roughly 2 to 5% of cases, but carries a devastating 60 to 90% mortality rate. PPPE is not standard cardiogenic volume overload resulting from heart failure. It is an iatrogenic condition mirroring acute respiratory distress syndrome, characterized by severe capillary hyperpermeability. This micro-level diagram illustrates the cascade. First, severed lymphatics severely reduce the lung's thicacity to drain fluid. Second, as the remaining lung hyperinflates, barotrauma creates microtears in the capillary endothelium. Finally, excessive intravenous fluid crosses this damaged barrier, completely drowning the alveoli. To prevent this cascade, current clinical guidelines mandate rigid fluid restriction. Intraoperative and postoperative fluids must be kept under 1.5 liters in 24 hours, or approximately 10 milliliters per kilogram. Patients with PPPE present with rapidly progressive dyspnea and radiographic edema, often after an unremarkable first 24 hours, even if their baseline pulmonary function tests were entirely normal. The salvage protocol for established PPPE involves immediate diuresis, continued fluid restriction, and low-pressure ventilation to limit any further barotrauma to the remaining lung. For cases that are refractory or unresponsive to standard therapies, Early initiation of ECMO, extracorporeal membrane oxygenation, is emerging as a necessary bridge to recovery to rest the single remaining lung.
Because pharmacological treatment is overwhelmingly ineffective once established, militant fluid restriction remains the single most important hemodynamic intervention in post-pneumonectomy care. The third differential is an early bronchopleural fistula, or BPF. This represents a primary technical failure of the sutured or stapled bronchial stump, typically occurring within the first 14 days. This cross-section explains why BPF incidence is heavily skewed toward right-sided procedures. The right main sen bronchus is structurally disadvantaged, wider, shorter, and more vertical than the left. Furthermore, it relies on a single fragile bronchial artery, compared to the robust dual muscle network on the left. Overt clinical signs of an early BPF include a massive continuous air leak in the chest drainage system, or rapidly progressive subcutaneous emphysema, where air becomes trapped under the skin. This split-screen diagram highlights an occult or silent BPF. While the left side maintains a normal, high fluid level in the empty cavity, the right side displays a sudden drop in fluid volume, indicating the fluid is being aspirated backward through the fistula. If a patient deteriorates with a suspected BPF, they must be positioned operative side down with their head elevated. This uses gravity to prevent the infected fluid in the empty space from flooding into the remaining healthy lung. For high-risk right stumps, such as in patients with diabetes or those who have undergone neoadjuvant therapy, the intercostal muscle flap, or IMF, is the surgical gold standard for reinforcement. Surgical salvage for an early BPF requires an urgent rethoracotomy to resuture the stump and apply immediate vascularized tissue coverage over the repair. The right-sided anatomical vulnerability guarantees that early stump failure is a predictable mechanical breakdown. It mandates proactive, vascularized reinforcement from the very first incision. Once the patient clears the acute 30-day window, the operative risk shifts. Over months or years, the primary threat becomes structural space collapse. This biological vacuum causes post-pneumonectomy syndrome, an extreme, progressive mediastinal shift as surrounding structures get pulled into the empty hemithorax. This axial cross-section illustrates the mechanical consequence. Following a right pneumonectomy, a counterclockwise rotation of the mediastinum severely stretches the airway, ultimately crushing the trachea against the rigid vertebral column. In adults, late-stage symptoms include dyspnea, stridor, recurrent infections, and orthopnea. These result directly from tracheobronchial malacia, the softening and collapse of airway cartilage under pressure. Definitive treatment restores anatomical position by filling the pleural void with expandable prostheses, commonly saline breast implants. As they expand, they physically push the mediastinum and trachea back to midline. If permanent malacia has already set in prior to the operation, expandable airway stents are occasionally required to hold the trachea open from the inside. The empty hemithorax is never truly static. Without intervention, the body's attempt to fill the anatomical void will inevitably cannibalize the function of the remaining airway. The final chronological threat is late bronchopleural fistula and post-pneumectomy empyema, severe infections occurring weeks or months post-discharge. Late BPF is usually driven by ischemic healing failure or residual tumor at the surgical margin, or the rupture of an active empyema directly through the bronchial stump. These patients present with high fever, systemic toxicity, and a productive cough of purulent, blood-tinged, or frothy serosanguineous fluid. Because the surrounding tissue is severely infected and necrotic, late failures cannot simply be resutured. This multi-step flowchart outlines the required management, a complex, staged pleural sterilization protocol. The first phase of the Clagett procedure creates an Allocer flap, a U-shaped window in the chest wall permitting continuous, gravity-fed drainage alongside intensive mechanical cleansing. Once tissue cultures return negative, the final phase involves closing the bronchial stump with a massive vascularized flap, such as the omentum, and filling the space with an antibiotic solution. Throughout this grueling, multi-staged recovery phase, maintaining aggressive nutritional support is critical to allow the patient's tissue to actually heal. The true success of a pneumonectomy doesn't end at fascial closure. It requires a lifelong commitment to anticipating chronological failure, mandating a specialist's mastery over both microvascular hemodynamics and macrostructural space management.